So today, oh, by the way, I'm Jenny McGaughy. For those of you that don't know me, I think I know just about everybody in here. I work here at the Perryton Health Center. I'm a family practitioner in town. Dr. Leong is our radiologist. He works both here and at Dumas. So he's here to expound a little bit further on kind of some imaging techniques for what we're discussing today. So I'm going to get started, start talking about some women's health, and then he's going to jump in at the end. So we want to make this very interactive. If you guys hear something that brings up a question, you have something you want to share or talk about, let's stop and talk about it. I don't have a huge presentation with a ton of slides to bore you, but I thought it'd be nice to bring up some things that might update some strategies and some prevention techniques for everybody here. So women's health obviously is a big issue. One that I have a lot of dealings with because number one, I'm a woman. And it's very important to me. Plus, being a female practitioner in a small town with a lot of men running around, I do get a lot of the women coming to me asking questions and stuff about women's health. So moms, women, whoever, whatever, usually the ones that are bringing people to the doctor and taking all the kids and the dads and the grandparents, but a lot of times they kind of forget they have to take care of themselves too, you know, those mammograms and things like that. So we're going to just go over a few things today. Today we're going to talk about cervical cancer, osteoporosis, and then Dr. Leong's going to touch on breast cancer. As everybody is aware, October's Breast Cancer Awareness Month. All the pink everywhere you see, of course, is in honor of that. So it's a good time to talk about it, and it's a good time to get out and get those mammograms done. So we're going to get started with cervical cancer. So you and your cervix, for those of you that still have one. For those of you that never have one, you can close your ears. So just a brief anatomy. Everybody probably knows this already, but you have several parts to the female genital tract, the cervix being the bottom part of the uterus, your fallopian tubes, and then your ovaries. That's kind of how it looks. So cervical cancer is the leading cause of cancer death in women. A lot of people think it's breast cancer, but it actually is cervical cancer. So in 2013, there were over 11,000 women diagnosed, with 4,000 of those actually dying from cervical cancer. So it's very impactful, very important to the younger woman, actually. Most cancers that we deal with and treat are oftentimes at later parts in your life. Cervical cancer is one that hits a little bit earlier, so it becomes more of a concern. So peak incidence is after 40 years of age, and as we all know, 40 is not old, and so it's a cancer of the young woman. And almost all cases are due to HPV infection. There have been some reports and speculation that there could be a couple other little tiny causes for it, but by far, on a whole, what we see most of the time is HPV. And we will talk about HPV here in a second. So in the past 40 years, a lot of the data has shown that we're seeing a decrease in cervical cancer because of the increased regularity to pap smears and people going to their doctors and getting things, like we just know more about it. So we're checking it out, we're treating it earlier so it doesn't progress to actual cancer. So with cervical cancer, there really is no symptoms. Most people don't even know they're having a problem. Advanced cases can cause bleeding or some abnormal discharge, things like that. But on a whole, you don't really know you have a problem with it until it's advanced. Treatments include surgery, chemo, and radiation, just like any cancer. There are, just depending on staging and stuff like that, and that's a lot of details that we won't get into today, but there is treatment for cervical cancer. The HPV virus, or the human papillomavirus, that's kind of a pretty popular topic. You guys have probably all read about it, heard about it, or are familiar with it. It is the most common sexually transmitted infection in the United States. So this is what causes cervical cancer. So cervical cancer is caused by a sexually transmitted virus, pretty much on a whole. There are we know about 40 types of HPV right now. They've kind of figured that out. Types 16 and 18 cause most of the cancers. So we know even specifically which type. If you have this type, you're at risk for cervical cancer. The 6 and 11 cause about 90% of like genital symptoms, genital warts, and things like that. Most people, I say to my patients, 9 out of 10 are going to be completely asymptomatic, not have any problems. You have HPV, it's probably going to go away, it's probably not ever going to cause any problems, but it's that 1 in 10 person, or that 10% of the population, that it is going to kind of progress and cause some problems. You're going to have to kind of watch it. Genital warts, as you probably know, it's probably not a topic for lunch, but it's more a cosmetic problem. It's not really, there's not a lot of cancer concern for that. But you know, for women, that's a big issue, having those. So knowing about that and getting that treated and seeing your doctor about it is very important. Persistent HPV, like we were saying, the ones that don't go away, the 10% of the population can progress to cancer and more problems with the warts. So again, I just wanted to reiterate that HPV is the cause of cervical cancer. Risk factors for HPV: multiple sexual partners, obviously. If it's a sexually transmitted virus, the more partners you have, the more risk you are of getting this virus. So I always tell my patients, I'm like, well, I've only had, one partner. Well, how many partners has your partner had? And you start to look at that and you see that, and let's make a little tree and think about it. Sometimes it can be pretty substantial, even though you've only had one partner. If your partners have other partners, you're still at risk for that. Sexual intercourse at an early age predisposes women to be infected with HPV. The cervix is very naive, and it takes a while as the woman develops for it to kind of mature and get to where it needs to be. So that naive part of the cervix, the cellular part that kind of comes out, is very sensitive to that virus. So it can cause a lot of damage kind of early on. So waiting to have intercourse until much later, letting that cervix mature, letting all those cells kind of go to where they need to be is a lot better. Of course, we all preach this to our youth, and trying to get them to abstain, push back that sexual experience to much later in their life. STDs, or sexually transmitted infections, obviously, if you have those, then the sexual history is there. Smoking. Smoking is a risk factor for every cancer, and it's the same for cervical cancer. So smoking does increase your chances. Condoms are important. We preach that for sexually related infections and for prevention of pregnancy, but it's only partially protective of this particular virus, because this virus is skin to skin, and everybody knows how that works. So it's only partially protective. So we do have vaccinations, and this is something that I love to talk about, because vaccinations typically have been for, infections and, ear infections and pneumonia and chickenpox, but we have a vaccine that you can give to your youth to prevent cancer. We don't have it for any other cancers. This is it. So this is really spectacular. We have 3 that are available right now. One, it covers 2 types of HPV, the 16 and 18, the ones that cause cancer. This is only for women, that they're the only ones that really benefit from this, because they're the only ones that can get cervical cancer. Not many people are really using this one, because we have the next ones we're going to talk about. Quadrivalent has 4 types, so it helps with cancer prevention and the wart prevention. So you can give this to boys and girls. The package label says 9, doesn't it? For Eva, it says 9, but we're pretty much giving it at 11. Most of the guidelines, you can start vaccinating with this at 11 years old, and you can go all the way up to 26. And the question I get a lot at this point is, well, what if I already have HPV? I've been told by my doctor, and I'm 22. Go ahead and get the vaccine, because we don't know specifically what type you have. It's better to go ahead and get that. Go ahead and get it on board. You might as well. It's not going to hurt you to do that. Most recently, we have a 9-valent vaccine, which is really great. It's got more of the types at the end, the 16, 18, on 31, 33, all those types there. Those are cancer-causing types, so we know more about those. So you get more bang for your buck in that one. And we here in the clinic have switched to this vaccine because it is more effective. Can be given to boys and girls. I am recommending that all the boys have it. It's kind of a touchy subject sometimes with moms, and we're in there talking about 11-year-olds, 12-year-olds, and an STD and a HP. Where does that fall? How do I spin that? Well, I had a mom tell me this the other day. She says, it was her son, she says, you're gonna get this vaccine today, and 10 years later, I'll tell you why. So I kind of thought that was good. I was like, well, you are the mom, so you're gonna do it. But for those parents that are skeptical, like, my kid is not gonna get this, my kid is not gonna have sex, I'm not gonna give this vaccine. Well, I try to say, well, I'm not really saying that. I'm not really saying that your kid is going to, but what I'm saying, let's protect them for their future. And if you have a little boy, let's protect your future daughter-in-law. You don't want you may have a son, but you don't want your daughter-in-law going through this. Now, men are not going to get any kind of cancer from HPV. Very rare that they would get anything. They kind of miss out on a lot of that. You're outnumbered. But they can get the wart symptoms, and they can transmit it back and forth to women. So they are carriers, and they are involved. And so it is very important that we look at prevention and trying to get these vaccines on board, and the earlier the better. They're saying between 11 and 13 years old, the better. So you have that naive cervix I was talking about before. There's even some idea that it's kind of incorporating into their DNA, and they can transmit it to their children, this immunity against the HPV virus. So that's kind of interesting too. So the earlier the better, boys and girls. Try to get more bang for your buck if your provider has it. It is out there, and it's widely available and covered. Most insurances are paying for it, no question. It is not required. It's not a required vaccine, so it's not like at school they're going to get a letter. Someday, I imagine it probably will. I just don't know. When it first came out, you guys probably heard about how they made it mandatory and everybody freaked out. You're not making my kid get this sex vaccine, and so then they had to back way off. And so it may be a while before we see that come back, but.
Still has that program that if you do not have insurance or your insurance will not cover it,
Then they can get it, pay for it. Yeah, we've had tons of kids get it through a free program too. I mean, we just pretty much, they come in at 11, they get their tetanus booster, they get their meningitis, and then they all get HPV shots. So most people go for it, especially if we kind of teach them about all this. So the PAP exam is recommended for all women ages 21 through 65. Guidelines have changed over the years, and a lot of my patients laugh at me when I say this because we used to do PAP exams every year. And come in for your PAP, come in for your PAP. Well, if you're under 21, you really don't need one. It's the new guidelines. 21 to 29, you only need one every 3 years. 30 to 65, you need one every 5 years if your doctor does the co-testing for HPV. So most of us are doing that. What they're finding out is we were doing PAPs every year, and we were, okay, you have HPV and you have HPV, and people were starting to do aggressive treatments and freeze the cervix and cut parts of it out, and it was just all the costs, and really they found out it goes away on its own 90% of the time, so don't do all that. So rather than kind of change that, they just kind of pulled back the guidelines, kind of, watch it a little bit closer as you get older to that peak age in the 40s and that kind of thing. Now the co-test is an actual PAP where you get your PAP exam done, and that goes to the lab. They spin down the cells, they look at the cells, and they actually test for the HPV virus. So in the younger population, that's only done if it looks abnormal. Then it automatically goes to be tested, so you don't get that. But as you get older, we need to know, do you have HPV? Now, those guidelines will probably change. If yours came back positive, then your doctor's probably going to say, well, everything looks fine right now. You have HPV. We're going to do it again in a year, and just watch. Getting real aggressive with treatment and stuff like that can't, especially in the younger woman, it can increase their chances of infertility. You start hacking at that cervix. I mean, that's important for pregnancy, and so it can cause problems. And so we have to be very, very conservative with our younger patients. That's right, and that's a great point. That's a great point. And the reason they're saying that is because at that younger age, 90% of them, it's going to go away on its own. So the temptation to treat it, we need to treat this, it's probably like just stand back and watch. I sometimes get a little irritated at the guidelines because I think it's like, well, don't check, you won't know. If you don't check, you won't know. But they've just done enough research to determine that most of those age girls, it's going to go away on its own. And it's not going to be a problem until they're much older. So we'll as they get older, we'll start looking at it a little bit closer. But when they're younger, our focus is on prevention and education and stuff like that. But I mean, you're absolutely correct. I have 12, 13-year-olds already very sexually active, naive cervix, and I'm not going to examine them until they're 21. So, and that's individual. I mean, I do a lot of these exams on younger women. I go ahead and say, you know, you have enough risk factors. I'm going to go ahead and examine you and do a Pap test because, you know, you've already been having intercourse for 6 years. So it's time to look. And sometimes we do find things, and it just puts our monitor up. You know, we're watching closer. And these are guidelines, and it's individualized, and it should be a decision that you and your physician kind of decide together and how you should monitor and stuff like that. But I mean, that's a great question because I think of that all the time. I'm delivering 13-year-olds. They're having babies at 13. They've been having intercourse for a while. This is an issue, so. The greater than 65 Pap not being necessary, that's very popular. A lot of my patients in that age group do not want to have this test done, and they're saying at this point, pretty much if they're going to have had cervical cancer, they already would have gotten it. So at this point, you can decide if you want it or not. Now, I do have some patients that I'm here for my exam and they want everything, and that's fine. That's an individual approach, and that's fine. So, any questions on that one? That's kind of a... Yes, Medicare still does. Medicare hasn't caught up, but Medicare is going to catch up. So Medicare sets the standard for all of what we all get paid for, and once Medicare figures out all this, then all the other insurances will trickle on. So I have a lot of people that still want to have yearly exams, and that's fine, and I'm still doing it as long as Medicare will allow it. I think that eventually Medicare will start to back up and say, wait a minute, you know, you've had a hysterectomy, or you had, you know, and they probably will start changing that a little bit. Medicare's changing big time for us anyway next year, and a lot of this is going to change. So there's going to be a lot of discussion between you and your provider on what's covered and what's not. Limiting early age of intercourse and number of sexual partners, and while condoms aren't completely protective, they're at least better than nothing. So we want to encourage people to be using condoms. Vaccinations between the ages of 11 and 26, smoking cessation, your Pap smears and physical exams, and then treatment of persistent HPV. So between the ages of 30 and 40, if you're getting those positive tests, it's either making sure you're following up, you have a treatment plan in place, whether you're doing just watching or treatment in the clinic. We do freezing, we can cut parts of the cervix out if we have to. We monitor it very, very closely, so we do a lot of that. I spend a lot of my day talking about HPV. So the other thing is a Pap test is just the test, but the yearly female exam is way more important. So there's a lot of other things to be talking about: birth control, hormone replacement, STD risks and screening, breast exams, your mammograms, if you're having urinary or bowel issues. For women in the right age group, osteoporosis and other medical problems. So a lot of people think your visit is just your Pap, but it really isn't. It's really kind of this whole female, we're going to talk about everything kind of problem. And like I said, women oftentimes put their whole family first, but these are issues and things that we have to talk about. So someone comes in, I want to, talk about their reproductive history, all of this stuff. We'll do all these exams if they're needed, but we also need to talk about heart disease and risk for other things like that. So woman exams need to be done every year, and insurance will pay for a preventive exam every year as well as Medicare. Any questions on that? Okay. So the next topic that I wanted to touch on real quick, and then Dr. Leong will take over, is osteoporosis. Another issue that women have to be concerned about. It's a chronic progressive disease, and it's characterized by low bone mass. My patients will say, I have that low, my bones are brittle, my bones aren't strong. It's a deterioration of the bone tissue, the bones are more fragile, and then of course with that, you're at increased risk for fracture. 50% of women are affected by that, have some kind of fracture from osteoporosis. So It's huge, associated with a lot of disability. A lot of women end up, with a lot of problems, broken bones, broken hips, and they end up in nursing home. A lot of healthcare costs associated with that, and death. Osteoporosis is not going to cause death, but it's that hip fracture that you get that gets you so debilitated that you end up with pneumonia, and then you end up dying from something like that. So we don't see people dying from their hip fracture. We see them dying from the complications that occur after they've broken their hip. So risk factors, just like anything: excessive alcohol intake, greater than 2 drinks per day, caffeine intake, greater than 2.5 cups of coffee. And I brought my coffee. I was telling, when I was making this presentation, I was drinking coffee, and then I come to the presentation, I've got coffee. So I need to practice what I preach. Tobacco use also is a risk factor for osteoporosis. If there's a family history of somebody who's had a fracture, osteoporotic fracture, that's a big red flag. Sex hormone deficiencies, women that have gone through premature menopause. The average age is 51, but if you were 41 and you went through menopause, you're no longer having your natural estrogens and your bones start to deteriorate sooner. So you're at higher risk for fracture. If you've had a hysterectomy with both ovaries removed, you don't have your natural hormone, you're not on hormone replacement, you're at higher risk for osteoporosis. Immobilization, inadequate activity, and low body weight. This is the one disease or disorder that the skinny women have to deal with, okay? It's usually the other way around. The women that are overweight, they have all the things to worry about. If you're overweight, you're not at risk for osteoporosis because you're carrying extra body weight. That doesn't mean we all need to go out and gain weight. We need to stay in the middle. But if you're a low body weight, thinner frame, you're at higher risk because you're not carrying all this weight around. Your bones are not getting that weight bearing that's necessary to make them strong. If you've had fractures in the past, if you've been on chronic steroids for lupus or other disorders, smoking again, and then the white and Asian races seem to have higher incidence of osteoporosis. So the screening recommendations are for all women 65 years and older. I hate this guideline. I think we should be starting it sooner. I think we see issues earlier, and I think a lot of us do start screening early. But all postmenopausal women who've had a history of a fracture or have any kind of risks for osteoporosis should start that screening earlier. I typically start my patients at 50 because I can pretty much find one of those risk factors for them. And Medicare and insurance will pay for that if you do that. So you can see that evidence on x-rays if they've had an x-ray, if they're on steroids, or other risk factors like if you've had rheumatoid arthritis, you're at higher risk too. So smokers, early menopause, if you drink a lot of alcohol, low body weight, any of those risk factors we should start screening earlier.
So if we get through menopause early, we need to, we were talking about usually the older women go through it. I can't even say that what I'm trying to say, but how soon should you?
And that's kind of individualized because you do have a risk factor if you went through menopause early. You do have a risk factor, so your screening can be started at 50. So, and it should be every other year that you should have that done. Because that premature menopause or early menopause, you've had that decreased estrogen protecting your bones for all that time. So,
Thank you.
you're welcome. That's a good question. So they don't recommend screening any more frequently than a year or two. In fact, a lot of people frown on doing it every year. You don't get a lot of new information in a year, so it's typically a 2-year interval. And I have noticed Medicare will not pay for them every year. They will pay for them every other. And then based on higher risk problems, issues, and things, sometimes you do have to do them more frequently. But on a whole, this is something you can get away with about every other year. So how can you prevent it, or how do you treat it? Well, don't fall, that's a big thing. Don't fall. Quit smoking, modify your coffee and alcohol intake, diets consisting high with vitamin D, calcium, protein, vegetables, fruit, all those things we know we're supposed to be doing. If we do that, that does help. Multi-component exercise with strength and balance. So it has to be that weight bearing. You have to be doing some kind of So I'm walking. I walk at the expo every day. Well, walking is great. It's great for your heart and all that, but it's not weight bearing. So grab you some dumbbells. Put some ankle weights around your ankles. You need to get that weight bearing. It's really important. There's tons of websites out there that give you weight bearing exercises and things you can do to strengthen your bones. We used to have that Curbs here in town, and that was like the best for osteoporosis type, because it's just the bands and the resistance and the weight bearing. Those are very good exercises for osteoporosis. Sunlight exposure, they recommend 30 minutes a day, 5 days a week. Vitamin D supplementation, your calcium supplementation, and medications that could be prescribed if you truly are osteoporotic. The decision may be between you and your doctor to go ahead and start medications to build that bone. So I have a question for you guys. How old are you when your bones start to deteriorate? Throw out a number. How old? Anybody know? What was it?
40.
Close.
30.
35. So at 35, you reach your peak bone density. And so after 35, it's just like, and it's part of the way the bones are and the way that our bones and the body reabsorbs calcium and all that different things. So we have to start at 35 replacing calcium and vitamin D in our bodies. So that's another thing. Those yearly checkups are real important, because I want to talk to my women at 35. Are you taking your calcium? Are you taking your vitamin D? Because this is when you need to start strengthening your bones, preventing those fractures for when you're 70. You may not think about it now. You probably don't need it right now. Calcium is not really necessary. You're doing fine. But when you're 70, you're going to wish you had taken it when you were 35. So between 19 and 50, I just put this table together. You need 600 international units of vitamin D with 1,000 milligrams of calcium. I always tell my patients, just go with the higher, the 1,200. Most of your calcium supplements come in a 600 milligram tablet. Oscal D is a 600, and it has 600 of vitamin D in it. As you get older, 51 to 70, you do need a little bit more calcium. Your body doesn't absorb it as easily, so you need a little bit more to kind of hit all the spots where it needs to go. Of course, pregnant women need a little more calcium, and breastfeeding women need a little bit more calcium. So one thing, where was I going to mention that? Vitamin D comes in the way it is, it's not a milligram. You guys have probably seen that. It's an IU, which means international units. Okay, so if you see that on a bottle somewhere, that's what that means. So for the average, 600 of vitamin D, 1,200 of calcium. Just keep that in your mind, pretty much for everybody. But calcium has to be taken divided. You can't take 1,200 milligrams of calcium right here. Your body will only dissolve or absorb half of it. So to make things more confusing, you got to take one in the morning and one at night. So now they just came out with a calcium tablet that's controlled release for this reason. So if you find the controlled release one, you can get away with it because it slowly releases calcium all day long. Talk to your doctor about this. Some medications can interfere with it. If you're on thyroid replacement, you can't take your calcium and your thyroid together. They have to be separated. So just, if you're concerned about calcium, you're on a lot of medications, may need to be a conversation you have with your physician. Calcium can be constipating. A lot of women say, I don't want to take calcium, it just makes me constipated. Citracal tends to be the one that's best for constipation, just as a whole. Some women just opt to take Tums. You take Tums for heartburn, there's calcium in there. So if you have heartburn, you can get away with treating your heartburn and your calcium requirement all the same. But just drinking milk and just getting out in the sun is not enough. We're finding that out. So we do have to do replacement. Even if you're healthy and active and all that, you still got to replace your calcium and your vitamin D. And that's what I have. Any questions about?
One thing with the vitamin D, I don't know whether some of you know this, but now I go to Dr. Brent, he's an endocrinologist, and I've had one parathyroid gland removed. The vitamin D I take 2 hours after the Central, which is one of the 4 my thyroid.
Yeah, there's a lot, a lot of things you have to, people think it's over the counter, it's a vitamin, it's no big deal, but if you're on a lot of different medications, it's important to discuss with your provider, like, how should I be taking all these? And they should be aware of what supplements you're taking. Well, I'm glad you brought that up, because we're starting to diagnose more vitamin D deficiencies in women. Women are fatigued, we have bone pain, we ache all over. Well, we found out a lot of women are just deficient in vitamin D, and you actually need a prescription strength vitamin D tablet. So we're doing that a lot. We give women monthly or weekly vitamin D prescriptions that they have to take. So sometimes that has to be checked into as well. Can you get too much? Your body only will absorb what it needs.
So some of those like glucosamine supplements and stuff don't
They have.
like 2,000 calories.
Yeah. No, obviously if you took the whole bottle, you probably would get into trouble. But with vitamins, that's kind of the way vitamins work. There are only a couple vitamins, like vitamin A, for example, that can be toxic at very large levels. But most of them, your body just kind of uses and then you kind of pee out the rest. That's why your urine is bright yellow when you take your vitamins and stuff like that. So, and that's the way calcium is too. You can take 4 calcium tablets all at once, but you're only going to absorb one of them. So, and vitamin D works that way too.
One other question I had was, on the osteoporosis, I've had bone density tests before. Is that what they're for? Mm-hmm. Okay, I thought so.
Yes, and that's what, I didn't put that in there because I thought I would steal Dr. Leong's thunder. And so he's going to talk to you about bone density, the actual test, and kind of what that means. So, anybody else? Yes, ma'am.
Is there anything you could take that's not like those vitamins, but like you can't have milk to replace the calcium? Is there anything you can eat or drink, not literally?
That has like calcium in it, or to be at the right level to get you where you need.
Yeah.
It's going to be real hard. You could probably start in the morning and eat kale until the sun goes down, and you probably still wouldn't get enough. So it's really hard to just get it through your diet, and especially at the level that we need to preserve our bones. So you do have to add some stuff in there. And a lot of people think, well, I get this a lot. Well, I eat cheese and I drink milk. It's like, well, that's good. I'm glad you do, but it's not enough. You really got to get more.
Dr. McGaughy covered it quite thoroughly about the incidence and pathophysiology of it. What we're going to be talking about is the bone density test that evaluates for osteoporosis. It's a disease that causes bone to become more fragile and more likely to break. In the past, osteoporosis could be detected only after you broke a bone, and by that time, your bones are considered too weak. So a bone density test enhances the accuracy of calculating a risk of breaking bones. And this test uses X-rays to measure how many grams of calcium and other bone minerals are packed in a segment of bone. And this is most commonly tested in the spine, the hip, and the forearm. The doctors use bone density testing to identify decreases in bone density before you break a bone, and determines your risk of broken bones or fractures. It confirms the diagnosis of osteoporosis and monitors your osteoporosis treatment. So the higher your bone mineral content, the denser your bones are. And the denser your bones, the stronger they generally are, and the less likely they are to break. Although osteoporosis is more common in older women, men also can develop the condition. Regardless of your gender or age, your doctor may recommend a bone density test if you're losing height. If you're losing at least 1.6 inches or 4 centimeters, you may have a compression fracture in your spine. And osteoporosis is one of the most common causes of compression fractures. If you have fragility fractures, which is just having a fracture from coughing or sneezing, or some people think that when you have a hip fracture, that the bone actually fractures and causes you to fall rather than you falling and having a fracture, that's a concern. If you take certain medications like long-term use of steroids, that can predispose to osteoporosis as well. Also, if you are having an organ or bone marrow transplant, the rejection medication for these transplants can also cause osteoporosis by interfering with the bone rebuilding process. And also, if you have a drop in hormone levels, for example, if you're postmenopausal, like Dr. McGaughy had mentioned, if you're prematurely postmenopausal, or if you're getting treatment for prostate cancer, some of the medications for prostate cancer is to block hormone effects. That can also cause osteoporosis. Limitations of the bone density testing includes there are differences in testing methods. The one that we have here at Ochiltree General Hospital tests the central bones, which is the spine and the hip, and those are more accurate than testing the forearm or the calcaneus or fingers. And so we have the more accurate test here at Ochiltree General. It may not be covered by insurance, so you need to check with your insurance provider. The other downside of bone density testing is it doesn't identify the cause. It can only show that you've got low bone density, but it cannot tell you why. The tests are easy, fast, and painless. Be sure to tell your doctor beforehand if you've recently had a barium exam or contrast material injected for a CAT scan or nuclear medicine study. These contrast materials are dense and they can interfere with the test and give you a false sense of that you've got more bone density than you should. So if you have any of these tests, make sure you tell your doctor. The way the test is performed is you lie on a padded platform and a mechanical arm will pass over your body, and it's very low radiation, and so there's very little risk for cancer from this study. And the radiation is much less than from a chest X-ray. Results of bone density tests is you get a T-score, which measures your bone density per a small area in your bone, and this T-score is compared with a healthy young adult of your gender. And so your T-score is the number of standard deviations above and below this average bone density that you have in a normal young adult. So if your T-score is -1 and above, your bone density is considered normal. If it is between -1 and -2.5, you're considered to have osteopenia, and that is considered increased risk for fractures. And if it is -2.5 or below, you're considered to have osteoporosis, and you would be considered having a high risk for fracture. So that's my presentation about bone density tests. I'm going to talk about breast cancer, and there's a very good website called breastcancer.org, and the people on the panels for this website are from the most prestigious institutions in the United States and elsewhere as well, from Memorial Sloan Kettering, UPenn, Mayo Clinic, and so forth. It's a very well-informed website, and so I'm really stealing from that website. So. 1 in 8 women will have breast cancer in their lifetimes, and it used to be, when I started my training in medicine, it used to be 1 in 11, and so it's steadily increasing, which is concerning. For women in the U.S., breast cancer rates are higher than those of any other cancer. I think Dr. McGaughy said cervix is #1, but this site said anyways. But anyways. Besides skin cancer, breast cancer is the most commonly diagnosed cancer among women. In 2016, 30% of newly diagnosed cancer in women will have breast cancer. So 85% of the cancers occur in women with no family history of breast cancer. These are people who are women who have considered average risk for breast cancer. And the most significant risk factor is being a woman and growing older. So in 2016, there will be 190,000 people will have invasive breast cancer, and 60,000 women will have non-invasive breast cancer. So what do I mean by invasive and non-invasive? Invasive is that breaking through the normal confines of the gland and invading the blood vessels and lymphatics in the breast tissue. Whereas a non-invasive breast cancer, it remains confined in the gland. So in contrast, only about 2,000 cases of breast cancer will be in American men this year. So there's quite a disparity between women getting breast cancer and men. So according to the American Cancer Society, 1 out of 8 invasive breast cancer develops in women. This is about the age. 1 of 8 invasive breast cancer develops in women younger than 45, and 2 out of 3 invasive breast cancers are found in women age 55 or older. So that shows you the risk factor for age. Now, the other percentage of people who get breast cancer, 15% have a family member diagnosed with breast cancer. So you have a first-degree relative, for example, you have a mother, sister, or daughter who has been diagnosed with breast cancer, your risk for breast cancer doubles. So that's an important risk factor. That's why we asked in the questionnaire, have you had a relative who's had breast cancer? 5 to 10% of women with breast cancer are linked to a gene inherited from one's mother or father, and this is the BRCA1 or BRCA2 gene. And it's a relatively small percentage of the population, but if you have this gene, if the BRCA gene, you've got a 55 to 65% lifetime risk of developing breast cancer. And if you have the BRCA2 gene, you have a 45% lifetime risk of developing breast cancer. So that's quite significant. There are modifiable risk factors. You can maintain a healthy weight. If you're overweight, the increased amount of fat produces estrogen, and estrogen can predispose you to getting breast cancer. So if you try to cut down on your weight and try to have a body mass index less than, I believe, 25, that's the goal. Exercise regularly. Just exercising is an independent factor in decreasing cancer itself. Limiting alcohol intake, eating nutritious food, and smoking. Smoking is associated with every cancer here. In patients who are at increased risk of breast cancer with a family history or have the BRCA1 gene or BRCA2 gene, some physicians prescribe hormonal therapy like tamoxifen, raloxifene. You can see that up there. There are medications that are, some are approved by the FDA and some are not, but that's something that you should talk with your doctor about. And they have been shown to decrease breast cancer. And also, we may need to modify the current recommended screening guidelines, which are currently monthly breast self-exam, yearly breast exam by your doctor, nurse practitioner, and a mammogram every year starting at age 40. So if you have a first-degree relative who had a cancer age 35, you may have to start your screening earlier than that.
When should you have your first mammogram?
40 years. But if you're at high risk and you know a relative who's a first-degree relative who had a breast cancer and at a young age, and I've seen those, you may have to start your screening earlier.
They say 10 years earlier than the youngest first-degree relative.
Yeah.
What if you don't really know your family's history?
Well, usually you start 40, but also,
Close to 35, like should I have one now or?
well, the thing about that is that's where you need to do your monthly breast self-examination and have your breast examined by your physician or nurse practitioner so that at least they teach you how to do that correctly, and you really know your own self the best. So if you feel a change, you need to get that worked up. And I see quite a few patients who get an ultrasound before age 40 because a mammogram before age 40 is very difficult to see because there's a lot of dense tissue. I'll go over that. So women at increased risk for breast cancer, modified screening may start before age 40, and you can also consider an MRI of the breast or breast sonography. Now, patients with BRCA1 or BRCA2 genes having prophylactic breast and ovarian surgery is a controversial topic. So that's something that you need to talk at length with your provider. Screening mammography detects breast cancer in early stages. Breast cancer that is localized on breast and less than 2 centimeters size have 100% survival in 5 years. Breast cancer is not detected by self-breast examination or physical examination unless the tumor is at least 2 centimeters in size. When one is able to feel the tumor has a greater chance of spreading beyond the breast to lymph nodes and other parts of the body. That is why screening mammography is important. It can detect the cancer before it's even palpable. Here's some statistics. Women with breast cancer who follow annual screening program had a 12% risk of death. Women who had breast cancer who got mammograms every 5 years had a 25% risk of death, almost double from breast cancer. So it's important to follow the annual screening protocol to reduce your risk of death from breast cancer. Mammograms don't prevent cancer, but they can save lives by finding breast cancer as early as possible. It is the current best method to detect breast cancer less than 2 centimeters in size. Finding breast cancer early reduces your risk of dying from the disease by 25 to 30% or more. And finding cancers early with mammography has also meant that many more women are able to keep their breasts. When caught early, localized cancers can be removed without resorting to breast removal surgery like mastectomy. The main risk of mammograms is that they aren't perfect. Normal breast tissue can hide a breast cancer so that it doesn't show up in a mammogram. This is called a false negative. And mammography can identify an abnormality that looks like cancer but turns out to be normal. This false alarm is called a false positive. Dense breasts on mammography have less fatty tissue and more gland tissue and supportive tissue that surrounds the glandular tissue compared to the breasts that are not dense. Breast density can be inherited, so if your mother has dense breasts, it's likely that you will too. Up to half of women ages 40 to 74 years in the United States are classified as having dense breasts. So this is from the Radiological Society of North America. You can see, I'm not sure. The panel on the upper left is considered a fatty breast. To the right of that, it's considered having scattered fibroglandular tissue. This one is considered having heterogeneous breast densities, and this is when you can start missing breast cancer in the normal mammogram. And the one on the right, bottom right, doesn't show up as well on this slide, but it's considered very dense breast, and you can miss cancer very easily with that very dense breast. So dense breasts can make it harder for mammograms to detect cancer. Breast cancer on a mammogram looks white, same as breast gland tissue, and can be obscured by normal breast tissue. Research has shown that women with dense breasts can be 6 times more likely to develop breast cancer. And they've shown that it's not because we're missing the cancer, it's because it's an independent risk factor. So if a person has a false positive, you're worried about having breast cancer, and that means you're going to end up getting more tests and follow-up visits, which can be stressful. To make up for these limitations, more than mammography is needed. Women need to practice breast self-examination, get regular breast examinations by an experienced healthcare professional. In some cases, get another form of breast imaging, such as breast MRI, contrast-enhanced mammography, or ultrasound. I'm putting a plug in about contrast-enhanced mammography because we're one of 2 sites in Texas, in Dumas, that does it. And let me show you what that looks like. This is a contrast-enhanced mammogram, and this is what a regular mammogram looks like. And that is the contrast-enhanced mammogram. It subtracts all the normal tissue, and you can see the cancer right there. And the third panel is what a regular mammogram looks like. It has all these scattered densities, and with the contrast-enhanced mammogram, the cancer is right there in that circle. So that's what we're able to do. And that's what we've been doing for this community, actually. So it's a very important tool that we have that a lot of communities do not have.
You said only 2 or
About 2 places in Texas have it, yeah. And we're one of them. Well, Dumas, yeah, Moore County. Yeah, we are first, actually, yeah. Some women worry about the risk of radiation exposure associated with mammography. Modern day mammography only involves a tiny amount of radiation, even less than a standard chest x-ray. There is very low risk from getting cancer from annual mammography in women over age 40. Now, Dr. McGaughy was talking about young patients having naive tissue. If you're getting mammogram before the age of 40, in some ways, the breast tissue might be considered naive and maybe more susceptible to radiation effects. And so we try not to give mammography on patients before age 40. We'd rather do something like breast sonography or breast MRI if possible. So, but after the age of 40, the breast tissue is less susceptible to radiation effects, and that's when the cutoff is age 40. And the benefits from detecting breast cancer early far outweighs the risk of getting cancer from mammography. It's a fast procedure, it's about 20 minutes, and the discomfort is minimal for most women. And part of the key for decreasing discomfort is try to get your mammogram in the first half of your menstrual cycle, days 5 to 14 after the start of menses. And that's when the breast is least engorged by the hormonal changes from your menstrual cycles, if you're still having menses or menstrual cycles. If you're postmenopausal, you can get it anytime. So the value of screening mammography was questioned in November 2009 when the U.S. Preventive Services Task Force recommended routine mammograms for women with an average risk of breast cancer should start at age 50 instead of age 40. This recommendation is controversial and not universally adopted. In fact, the American Medical Association, American College of OBGYN, American College of Radiology, American Cancer Society, the National Cancer Institute, and the National Comprehensive Cancer Network all have issued guidelines saying that all women should be eligible for screening mammograms starting at age 40. And there's quite a body of literature saying that with screening programs starting at age 40, that has decreased the risk of death from breast cancer. So once a year screening mammography starting at age 40 years for women at average risk. You have a higher risk of breast cancer. You and your doctor may decide that you will start screening mammograms at a younger age, or if you're less than 40, maybe a breast ultrasound instead. And the coverage is mandated by the Affordable Care Act with no copay or deductible plan starting after August 1st, 2012. I'm not sure if that's still true, but I'm hoping that it is. And this is the last quote that I have. Mammography plays a critical part in diagnosing breast cancer. In the past, we'd often find that a woman had breast cancer when she came in with a lump. Today, the cancers radiologists find on mammography are usually detected early before they can be felt by the patient, are smaller than cancers felt by patients, and have much lower levels of lymph node involvement. And this is the head of breast cancer in UPenn, and she's published a whole bunch of stuff about this.